Talk.
Thank you so much, Mustafa. Thank you for such a nice introduction. Like all of you. So my name is Ahsan Ali Khan. I'm a senior instructor at the section of neurosurgery at Ahsan University. And I'm really honored and privileged to be talking at this forum. There are a number of reasons, so Ahsan University and Pakistan Academy of Neurological Surgery and also the Pakistan Society of Neuro-oncology, these institutions have become and organizations have become my identification and my introduction, I would say. And so I hope all of you who have joined will enjoy this talk, and I hope I can deliver my message effectively. So let's start. So the objectives in this talk that I would try to give, so that you have this understanding. I understand that there will be participants, with different level of understanding of for example, neuroradiology. There might be some students, some residents, and some young consultants as well, or some seniors as well. So maybe few of you will feel that's very simple, basic, and then but so I want to deliver you the talk that will cover the key imaging features of primary and metastatic spinal tumors, and also focusing on different compartments of the spinal tumors like intradural, extradural, and some understanding, when we get those lesions, when we have those tumors, how, we are going to the diagnosis that would ultimately lead us to the best management plan that we can offer to our patients. So this is the slide that I want all of you to see, remember, and you can go back, you can do Google, you can do so which compartment, so you will see a lot of tumors in your practice, in your residencies, in your student life, whatever. But so one of the very important and very first question, that you should ask when you're looking a scan, like which compartment it is. Is it intramedullary, it's extramedullary, or it's extradural? And so how we get an answer to this question, which compartment, right? So here I'm going to show you this. This is a cartoon, but you will see different examples on the MRIs as well. And I'll be explaining again and again this concept so that you understand how you will differentiate between intramedullary, extramedullary, and extradural tumors, okay? So for example, if you look at the intramedullary tumor here, so you can see the tumor is expanding the cord. That's one very important sign, one very important feature that you look when you're looking at your scans. So it expands the cord, okay? So when you're looking at the extramedullary, but intradural tumors, so what you can see is they are dural based, like this tumor, but they are pushing the cord away from the dura, right? So it's not pushing the cord, the dura, they're just pushing the cord away from the dura, and they're also causing this CSF space up and down, more. So that's kind of in these tumors, what you can see, the CSF space has been increased up and down as well, and the dura has been displaced away. So when we look at the extradural tumors, it's very important that, again, you have to remind yourself, these are simple things, but it will help you, all these things will help you a lot to differentiate and come to the right diagnosis. In the extradural tumors, you are looking or thinking about the epidural fat. Here should be an epidural fat, and then you can also think of a dura. In these lesions, dura along with the cord, you can say the pushing, and then what you can see is that here the epidural fat also, has been involved in this lesion. Okay, so this slide again is only right now. I'm not showing you any feature, but I just want you to understand that the spine imaging for the oncology is not only MRI or CT. There are different sequences that we look at, right? So there's T1, T2, T1 contrast enhanced, fat saturated, stir imaging, CT. So, and then I'm going to explain, further also like why we need, but one thing that you have to remember is that all these sequences complement each other. So you get one information from one sequence and then you are missing some point, and then another sequence gives you an answer. Like, for example, I said in intramedullary tumors, there is a cord expansion. So yes, intramedullary tumors cause this cord expansion, but there are some other demyelinating lesions also cause the cord expansion, right? So we have to have this understanding that for the spine oncologic workup, we need multi-model spine imaging. Let's start with the extradural tumors first. So again, right now, just showing you some text so that I want you to understand a few things so that before jumping to the scan itself. So extradural, whenever you're looking at the extradural, or when you look at the extradural tumors, so you will see T1, low signal tumor that stands out of high signal bone marrow. So, and why we need fat suppression, that also, you will see that how the bone marrow in the normal vertebra can be very bright, and that we have to suppress it in order to see the tumors, right? So on the extradural tumors usually are low signal on this. So stereo imaging is the most sensitive sequence for the extradural tumors. And the T1 contrast enhanced, they may be iso-intense. So that's why we need fat suppression, best to evaluate the epidural tumors. And it plays very good, I would say, a fantastic role, whenever you're going to distinguish between the disc herniation and tumor, because usually we do not go for the tumor contrast for when there is a degenerative disease, right? But when there's a diagnostic dilemma between the tumor and the disc herniation, that time the contrast enhanced can play a very vital role. So it's a list of some primary tumors. So when I'm talking about the extradural tumors, primary, mostly I'm talking about the primary bone tumors, right? So the hemangioma, osteoid osteoma, osteochondroma, chordoma, giant cell tumor, aneurysmal bone cyst, osteoblastoma. Not very common, but for the sake of this topic, I'm going to touch all of them in some detail so that you have an understanding. So let's start with hemangioma. So on hemangioma, these are the most common benign tumors of the spine, and it's very common in our practice. We see the hemangioma. Sometimes, it's like we just give the reassurance to the patient, like it's all right. Sometimes even, I have heard even radiologists say we don't sometimes even mention because it's a benign tumor. So, but we have to understand what is hemangioma, how does it look? And then rarely hemangiomas can also be aggressive as well. Locally can cause some symptoms as well, but it's mostly these are benign tumors and no need further any action. So these are fat, there are fat and vascular components. Here, if you see, this is the T1, and then you can see the high signal on T1 due to high fat. So that's one thing the hemangioma show you. And then not all the hemangiomas will be bright or will have this kind of appearance. So sometimes, they can have a different, level of the fat. So that time the CT plays an important role. Like I mentioned before, multimodal, we have to have this understanding of the spine imaging in the oncologic workup, that it's not only one type of scan or one kind of image, that we have to augment, we have to complement different scans with for getting the final diagnosis when there is some kind of question or some kind of dilemma in the diagnosis. So they have vascular channels and fat interspread, and some have low fat component, and those low fat components, now the CT will play an important role. So one thing that I also want you to remember, if there is something, any tumor that you see on T1 that is brighter, for example, like this tumor here, this is brighter than the normal bone marrow fat, most of the time you can be just relaxed. It's just benign tumor. You don't need to worry because it's like the tumors usually will have low, will be not bright, will have hypo-intensity because they change the bone marrow, okay? So when they have this hyper-intensity, have high fat content, so you can be relaxed that it's a benign tumor. So when they have less fat, low fat components, and we are not sure whether it's an hemangioma or not, so that time the CT comes in. So, I think, sorry. Can you see, Mustafa, can you see the CT slice here? Is it okay?
Yes, it's visible.
Okay, so when you look at, so in this one, you can see this axial CT, show the this is a typical classic hemangioma polka dotted appearance or salt and pepper appearance due to thickened vertebral trabeculi. So if you see this, and it's hemangioma. Okay. Now the second thing, second primary the bone tumor, the spine tumor is osteoid osteoma. So osteoid osteomas are benign bone-forming tumors. Typically, they are usually, they usually occur in the children, adolescents, and so here why I'm showing you the CT, because again, when you look at an MRI, you might be confused. Oh, maybe it's kind of a tumor, can be aggressive or something. But here the CT gives you this typical appearance of the osteoid osteoma. There is a characteristic lucent nidus here, and then there is a surrounding osteosclerotic sclerotic lesion. Why CT is important? MRI can tell you cord compression. MRI can tell you, different, for example, T1 can give you a very good understanding of the gross morphology of the tumors, of the contour of the tumors, boundaries of the tumors. T2 can give you good information of there is an apical site compression or not. But whenever it comes to the bone, for example, we want to see whether the lesion is lytic, plastic, sclerotic, where the cortex of the bone has been compromised or not, you need CT scan. So that's the best way to, when we are looking at these characteristics of the bone. So another type, osteochondroma, they are also benign bone lesions, very rare in the spine, usually involve the posterior elements, for example, a spinous process and lamina, composed of cancellous bone that's surrounded by the cortical bone and overlying cartilaginous scab. That overlying cartilaginous scab is very characteristic that we can see on the T2, and rarely they can transform into malignant tumor. So here is the osteochondroma example. There's a involving posterior element here, and the characteristic thing that I wanted to show you of this osteochondroma is this cap, this cartilaginous cap that you see. For example, now on this CT, if you see there's a cancellous bone here, and then this is a cap thing, or if you look at this CT, for example, you can even palpate it, you can even touch it. So, there are different opinion when it comes to the neurosurgery or the orthopedic surgeon, when to operate, when not to operate. So that's a very different discussion. So we always have to, correlate clinically. But so different kinds of tumors can appear in, totally different manner. So we have to know these things, if you look at this cartilaginous cap, next time on T2, you can start thinking of the osteochondroma, right? Okay, so now that's an important one, chordomas. They rise from the notochord remnant, involve vertebral bodies, may involve 2 or more adjacent vertebrae and intervening discs. So usually the tumors that I was showing you, they were involving a single vertebra, really not going to the disc space, but these chordomas can have involve multiple vertebrae, also the discs. 50% majority of the chordomas are in the sacrum. Second most common place for the chordomas are in the clivus, and then other vertebrae can also be involved. They usually have calcification, 50 to 70%, and the characteristic sign of the chordomas is like they have very high signal on T2. Other tumors can also have high signals on T2, but the chordomas have high signal almost like CSF. Okay, so that's very characteristic of the chordomas. The other thing that chordomas have very unique is like they have low signal capsule and septation. This you can see, for example, this is a sacral chordoma here, and you can see these septations, and the outer lining also is like low signal here, and this is very correct. This is a clival chordoma here. This is T1, T2. You can see it's more hyper. So in this one, if you look at this T2 and also this one clival, it's very hyper intense. It's almost like CSF, right? So if you remember these things, it will again help you to have chordoma in your differential diagnosis when you're looking at such scans. Again, like I mentioned, chordomas can involve multiple vertebrae. Here, if you look at starting from the C2 and getting up to the C5, also there is an anterior extension as well. Here, if you look at this scan, you can think of it's like involving transfer foramen as well. So it's like kind of extensive. And again, T2, you can see very bright on T2 chordomas. Giant cell tumors. Now, let's discuss the giant cell tumors. Usually in the sacrum, sometimes they can be in other vertebral bodies as well. Expansile lytic lesion. When I'm using the word lytic, sclerotic, I hope you understand, or like I'm showing you CT first, then I'm going to the MRI. Because whenever it comes to the quality of the bone, the lesions, like lytically and blastic, sclerotic, or when you're looking at the cortex of the bone, CT is the best, So in this, you can see is often associated with a large soft tissue mass here. As you can see, there's a lytic lesion here, and you can see these are the CT scan, the MRIs of the giant cell tumors here. Some heterogeneous kind of fluid levels as well in this. Osteoblastomas, again, not common, but we should know, usually in young patients, usually in posterior elements, whenever you have this kind of tumors, frequently involving some kind of epidural component, often expansile on CT. Here you can see this one, going to the spinal canal as well. Here you can see the involving the C3, and again, going, extending laterally, and it can, it's kind of for a benign lesion or this size is kind of quite significant. So now we come to the secondary, lesions of the extradural lesion. So, mostly we do not see the primary tumors. We see a lot of metastatic tumors as well. And these are some places, from where you get these tumors in the spine, the breast, lung, prostate, lymphoma, renal, melanoma. So again, that I think we have to repeat a few things like again and again, so that you will understand and you will remember. It's like most lesions are dark on T1, right? For example, in this one, you can see this is a T1 weighted image. You can see this is a dark lesion, and they will be bright on stir. They can involve any part of the vertebra. However, this is an important thing. Melanoma and hemorrhagic mets may be bright on T1, right? So, but like I said, sometimes if you see anything bright, almost it's a benign lesion, right? When I say that. But when I say I'm not making it a rule, I'm just talking about the majority. So that's how you can look at, you can make your differential diagnosis, it can narrow down your differential diagnosis, but there are always exceptions. So you have to think beyond those normal things that we always look in our clinical practice. Lymphoma can present as an epidural mass without bone involvement. Lymphoma has another unique ability to mimic any tumor, any kind of, like for example, all the compartments that I showed you in the the beginning, like extradural, extramedullary, intramedullary. Lymphoma can present almost in all those compartments. Intramedullary is very rare, but lymphomas can mimic almost like any tumor. So, okay, so when you have extradural tumors, there are some other differential diagnoses also. It's not always the tumor, right? So sometimes there are some mimics, like for example, spondylodiscitis, and sometimes a sequestrated disc fragment. So here is the T1, contrast enhanced, fat suppressed. Here you can see the fat, the bone marrow has been suppressed, and there is the sequestrated disc fragment. So if you look, for example, without going through that clinical exam and that background, you might, and usually because we don't do the contrast enhanced studies for the degenerative spine disease, we can get kind of confused, or sometimes can be like, oh, maybe it's a tumor. No, but that's why T1 contrast enhanced study is very good to show us how to differentiate between the sequestrated disc fragment with the extradural tumors. So here is the spondylodiscitis. Here you can see the T1 contrast involving two vertebrae and the disc space as well. Here's the stir image. You can see perhaps that also the abscess formation here. So these are the main differential diagnoses that we can think of and we're thinking of when we are dealing with the extradural lesions. And then there are some others, for example, facet joint, inflammation, synovial cyst. So there are a couple of others as well. whenever we have extradural lesion, we can think of those differentials as well. So now let's move to the next compartment. That's the intradural extramedullary. I'm going to start with the basic features of the MRI of it, what you're going to see. Radiologically, T1 tumors are hyper intense to CSF. So here's a tumor. I hope all can see my cursor. This is a tumor. And then here, this dark, area is the CSF. So these are hyper intense to CSF. On T2, these are hypo intense to the CSF. This is a tumor. You can see the CSF is quite bright, and the tumor is hypo intense, and all the lesions enhance. The intradural extramedullary, they always enhance, and the contrast enhancement is essential for detection of leptomeningeal metastasis. So I'm going to show you more scans of the leptomeningeal metastasis and how we see those in our practice. So when we talk about the intradural extramedullary primary tumors, we can just think of two options right now here: nerve sheath tumors and the meningiomas. Nerve sheath tumors can be further divided into schwannomas and the neurofibromas, but schwannomas are more common. So schwannomas are 30% of all the intradural extramedullary and 65% of intradural extramedullary nerve sheath tumors, right? So schwannomas can be solitary and sporadic as well. But if sometimes, whenever you see multiple schwannomas, you can think of NF2, right? So they have increased incidence in NF2. They're often lobulated. Neurofibromas similarly, can be solitary and sporadic, but usually they are associated with NF1, whenever you see multiple neurofibromas. Meningiomas, almost 35% in this compartment. So let's look at the radiological features of the nerve sheath tumors. So usually nerve sheath tumors are intradural extramedullary. Sometimes they can be extradural as well, but sometimes they can have this dumbbell shape here in this axial scan, if you look at, and they can cause the widening of the neuroforamen. In dumbbell shape, you can see there's an intradural component and the extradural component as well. So, and nerve sheath tumors, again, that include the schwannomas and the neurofibromas. On T1, this is a T1 image here. The iso-intense to the cord, right? So this was the case of the neurofibroma. You can see the multiple neurofibromas associated with NF1. T2, they have high signal on T2, and then they enhance intensely, but the enhancement is heterogeneous. And here in this one, if you look at the enhancement, and that heterogeneous enhancement is due to the cystic component. So now let's come, we are on the meningioma. So again, so I think I'm just trying to cover as much as I can in, this talk in 1 hour, but again, like it's a huge topic, but I hope I will be able to give you a good overview of this topic. So meningiomas have very strong predilection for the females, all more than 70%, almost like, what the patients with the spinal meningiomas are females. They are more common in thoracic spine, and the second most common place for the spinal meningiomas in the cervical spine. They are usually posterior in the thoracic here, like you can see in the, and more commonly, and when the meningiomas are in the cervical spine, they're more anterior. So I'm using again the word usually, but of course that's not always the case. Sometimes you might see meningiomas in the cervical spine posteriorly, and also you can see the anterior meningiomas in the thoracic region as well. Usually calcified, and when you look at the imaging, iso-intense to the cord. This is a T1 meningioma. You can say it's like almost iso-intense to the cord. And here also, if you look at this one, but this might be calcified, so that's more darker as well. And the enhancement is very homogeneous here. So they are iso-intense on T1 and T2 to the cord, but they can be darker on T2 if they're heavily calcified. And the enhancement will be homogeneous in meningiomas. So now, so those were the primary tumors in this compartment, like intradural and extramedullary. Now we are moving towards the secondary tumors of this compartment, and that's leptomeningeal metastasis. So leptomeningeal metastasis can occur due with two mechanisms. One is the CSF spread from the brain tumors, that the way we call it drop metastasis, or it can be due to the hematogenous spread to the CSF, that's the extracranial tumors like breast, lung, melanoma, and lymphoma, leukemia. So these are some primary brain tumors. Even brain metastasis can also cause a drop metastasis. So I want you to remember these three common appearances when we are looking at the leptomeningeal metastasis. So for example, fine layer of enhancement of the cord. Here you can see this kind of enhancement here, the cord, and the same kind of enhancement can also occur in the nerve roots. Focal enhancing nodules in the, subarachnoid space. You can see this like this. And diffuse enhancement. Here you can see the diffuse nodular enhancement of the thecal side. So these are the three common appearances of leptomeningeal metastasis. Okay, so now we are on intramedullary compartment. Again, so it's very important to remind or to recall what we saw in the beginning, how the intramedullary tumors will look. So on the intramedullary tumors will expand the cord. So here you can see intramedullary tumors will are expanding the cord here, right? So on the T1, the cord widening can be seen, good for gross morphology. On T2, you can see a high signal in the tumor, anedema, and low signal can be seen due to the hemorrhage. And on T1 post-contrast, almost all the tumors enhance up to some extent. That's very unique, because when you go in the brain tumors, not all the tumors enhance, only the high-grade tumors enhance, but the low-grade tumors do not usually enhance in the brain tumors. But in the intramedullary spinal cord tumors, almost all of them enhance, So that's a very, kind of helpful feature that we can have when we are trying to differentiate between the intramedullary tumors from some kind of demyelinating lesion, vascular lesion, when we have the differential diagnosis. So they will also, when you see a cord expansion and you are not sure about the diagnosis, you can think of, doing a contrast enhanced study so that you can think of like whether it's a tumor, it's a demyelinating lesion. So these are the three most common intramedullary primary tumors: astrocytomas, ependymomas, hemangioblastomas. Astrocytomas are usually infiltrative, low grade, and they have indistinct margin. Here you can see the margins are not very sharp, and they're relatively homogeneous, and they are more common in children and young adults. Here you can see this is a T1 scan. Cord expansion can be seen. This is a T2 again. You can see the cord. And then this is a T1 contrast enhanced fat suppressed image here of this astrocytomas. Ependymomas, the other intramedullary, the second most common. So ependymomas and the astrocytomas, only these two types of the intramedullary tumors make around 70% of the total intramedullary tumors. So, it's very important, like you have a good understanding of these two tumors. So ependymomas are more common in adult patients, and they have heterogeneous kind of enhancement. They are more circumscribed than astrocytomas, right? If you look at here. And usually small ones are usually located in the center because they originate from the epidermal cells. And there are two types in ependymoma. So one is the cellular, the other one is the myxopapillary. But the myxopapillary usually type 1, and they are on the conus or phylum terminale and often hemorrhagic. And myxopapillary will, can come under the compartment of intradural but extramedullary because, can be down, and the conus and the phylum terminale. Cellular ones are true intramedullary tumors. Here's an example of an ependymoma. You can see the cord expansion on T1, T2. Again, on the CIR image, you can see this is a tumor intramedullary expanding the cord. Expanding the cord, and if you look at the CSF space has been reduced, So like I said, when you are looking at the extramedullary tumor, but intradural, it will push the cord away from the dura, and the CSF spaces, these spaces, for example, if there would be a meningioma here, these spaces would have increased, But in this case, You can see the CSF space has been reduced. This level. Hemangioblastomas, third most common intramedullary tumor, often has small enhancing. This is a typical appearance of hemangioblastomas. They have often has small enhancing nodule and large cyst. Right? They are very vascular, usually intramedullary, sometimes intradural, extramedullary. Very rarely they can be extradural as well. You can see on a T1 image, T1 contrast enhanced. Right? So the secondary, now when we are talking about the intramedullary secondary tumors, they are not common. Intramedullary secondary tumors are rare and they're usually from lung, breast, and melanoma. So like I said, most of the time the tumor, the intramedullary lesions that we are having, the surgeons even would not get the intramedullary tumor, the lesions, because many of them are not actually tumors, that can be demyelinating, like for example, multiple sclerosis, myelitis, infectious, myelitis, sarcoidosis, idiopathic. Idiopathic is a good word. I think that all of us should understand when to use idiopathic, because whenever you do not, like when we do not know the reason of the myelitis, and if your professor asks you, what do you think, what's the cause? And our student or resident might say, I don't know, sir or madam. And the professor will say it's idiopathic. So essentially it means the same, but it's just a fancy way to say like we don't know the actual diagnosis. And the other thing, like the intramedullary mimics or differentials can be vascular lesions like infarcts, dural AV fistulas are usually missed, these ones. So DSA is the gold standard. So beyond, the scope of this talk, so that's why I'm not showing you these images, but just trying to give you a message that you should think of these, differentials when you're looking at the intramedullary lesions. So now I want to talk about compression fractures. So these are not tumors, but these are directly related to the tumors, right? So I think it's very important that if you have this understanding of compression fractures also in this talk. Compression fractures can be benign or they can be malignant, like due to some kind of metastasis disease or pathological fracture, right? So how we can differentiate whether this patient who is having a compression fracture is due to osteoporosis, it's a benign fracture, or is due to some kind of, malignancy. So it's very important. So there are some, signs that there are some, differentiating features when we look at the MRI. For example, the compression fractures which are benign, they would have normal marrow signal in old lesions. For example, this fracture is an acute one. You can see there is a difference between the marrow here, this one, signal, and this one is different. But let's say if this patient comes after 6 weeks or 10 weeks, then the marrow signal would be like normal. Okay, so they are low T1, they have low T1 signals and only involve the part of the vertebral body, often band-like. This might not show you the exact band, but can give you an idea. So usually it's like a line, it's giving you a band kind of appearance. And the other important thing in the benign fractures that you should, think of and you should remember is the total volume of the vertebral body is reduced. If you compare this with this vertebra, the adjacent ones, the volume has been reduced, right? And for example, if you decide like, okay, there is a fracture, but I want to have kind of a follow-up, and then I'll see again, and the patient is doing fine. There is no, so I'm not going in that discussion when to operate or when not to operate right now. But if you decide to follow up, so after 6 weeks, signal abnormality improves, right? Like I said, in the old one, the marrow signal is normal, right? So here you can see this is again, like the total volume has been reduced, and it's like involving kind of a band-like appearance. All right, so now let's look at the compression fractures, malignant, how they look, how they are different. So like, for example, in my previous slide, I showed you that the benign fractures are usually involving one band-like, appearance on the MRI, and one part of the vertebral body has been involved, but here the entire vertebral body has low signal. Okay, for example, look at this one, right? Look at this one. And the epidural and paraspinal mass is common. Total volume of the vertebral body is increased. That's very, I think that's one of the very important feature that we should remember, that the volume of the body in the osteoporotic fractures is reduced, and the total volume of the body in malignant fractures and malignant compression fractures is increased. And the other important feature is the retropulsion. So here you can see this retropulsion. It's not that much, but you can see much more than this kind of retropulsion, kind of a bulge of the vertebral body on the thecal side, is kind of a compression. And of course, there is a history of additional metastatic lesions as well. And there is no change, or if you are doing follow-up, the signal would not change, no change, or they can even, the things can get worse even on the follow-up. So these are, some distinguishing, I would say, like how you can differentiate between the compression fractures which are malignant and which are benign or osteoporotic. So I think, okay, yeah. So I want to, and now this thing is important, that take-home message from my side for this topic will be, location, location, location. When you can localize the lesion, you can think of differentials, and then differentials get narrowed down. And then again, think of multi-modal spine imaging. Then one modality can complement the other one. The information that has been missed on one modality can be picked up on the other one. Very important. Again, I want to just quickly go through these things. The intramedullary tumors will expand the cord. Okay, here you can see extramedullary tumors, which are intradural, they would push the cord away from the dura, and the CSF space above and below the tumor will be increased. And the extradural tumors will push the dura along with the cord, and then the epidural fat in these lesions will be affected, and you can see even being pushed away. And then when you have localized the lesion, then you can think, okay, whether it's if it's an intramedullary, you can think of an age. Okay, if it's an adult, you can again further narrow down to ependymomas, it's more probably than the astrocytomas. So the location is important. Once you have localized the tumor, then your differential diagnosis are more narrowed, and then you have a very good understanding what you're dealing with. And with that message, and I thank you all for your attention, and I would like to hear if you have any questions. Thank you very much. I think I was on time, or I was earlier. Okay.